The NHS is facing a perfect storm. Demand for quality healthcare is soaring as the population gets bigger and grows older. But budgets are being cut and it's harder than ever to retain a demoralised workforce. So what's the solution? Well, this is a programme that investigates whether a paradigm shift is needed within the NHS, especially in primary care, to keep the NHS as a world-class health system. Welcome to Breaking Boundaries and Beyond.
The NHS is the most revered institution, one that some experts say is at breaking point.
If you combine austerity and cutting the welfare state at the same time, which is what is happening at the moment, you kill people.
So what exactly is this paradigm shift that's needed to pull the NHS back from the brink?
We've got to think in an entirely new way about how we run the health service. We've got to create communities that create health for a start, rather than make patients worse. We've got to provide services around people's homes, in the communities, not bung them into hospital, especially if they've got dementia and don't need to be there. We've got to think radical.
Does radical mean accepting privatisation?
When it comes to delivering NHS care, that's to say care available to the patient at the time that they need it, to the quality that they need it, based on their clinical need, the thing that the patient really cares about is to ensure that that standard is met. And they're really not concerned, and the evidence supports this. They're not concerned whether the provider of the care is public, private, charitable, third sector or whatever.
The NHS does incredibly well, and care is probably now of a higher standard than it has ever been. The bad news is that I think most of us recognise that more of the same for another 4 or 5 years is not going to be sustainable.
Working collaboratively, better communication, using technology, are these really going to transform the NHS? There has been some success.
What we have here is a dashboard that shows the different costs before and after a cohort of people, a group of people together who have a fall.
In Derby, health and care organisations have been working together, using software to share their work, analyse workflows to improve the care they deliver and adapt to the government's Better Care Fund, spotting areas of high need and high risk before they become a problem.
The NHS and social care is incredibly rich in data. There's massive amounts of data and very little of it gets used. I'd say about, 10% of it gets used. And that does get used in silos. The important thing is to take the data from lots of different sources, that multiple layers, rich layers of data, and put it together, integrate it, cleanse it, put it together, match it, and then create the information and intelligence solutions that allow people to look at it in a very different way.
Using software, the vulnerability of healthcare provision to cuts in funding is clear. It showed after social care spend fell, several dozen people had a fall, social care costs and emergency hospital care costs rocketed.
We can't go on shipping more and more people to hospital. We've got nearly 1 million more over 65s than we had 4 years ago, and we've just got to get much better at looking after people in their homes, in residential care homes, in community settings.
But putting care back into community settings is a complex task, requiring a radical shift in the way different care providers coordinate. Back in Derby, and the software is helping health and social care providers to work more closely together. The new community health services and the city's healthy housing scheme are collaborating to transform care. 67-year-old Laura Bell McLaughlin has breast cancer, diabetes, osteoporosis and arthritis and high blood pressure. But despite her complex condition, is able to live at home.
We deal with Derby City Council, so healthy housing, which like a combination of the social service and the city housing. And that is kind of a joined up and not as fragmented as it used to be in the past. And they've been very excellent for us in providing the service we need.
It's no need just going to hospital because there's a hospital. We have to try and save.
digital technology is also empowering patients. Trevor Fossey had a stroke 5 years ago. He now uses an app to access his medical records online. One of hundreds of examples of how patients benefit from the rapid growth in digital health technology.
It's on my smartphone, it's also on my notebook. If I do have a relapse, even if I'm abroad, I can take my medical record out and show them. And then they're aware of the medications, they're aware of my summary record, which they're most interested in because it gives a quick summary of allergies and things like that. And I feel safer for that.
But with the rapid developments in technology come growing responsibilities and concern for the safety of patient data. There are also unacceptable delays. It takes far too long for many health professionals to make use of the intelligence that can be gathered from this vast resource of data.
One of the big challenges we have in healthcare is it takes some 17 years for half of clinicians to adopt the evidence base once it's known. If we can use technology to reduce the 17 years down to 17 months or even 17 days, then we can find a way to disseminate best practice very quickly so patients can get higher quality care much faster.
I think there's an unparalleled opportunity to move from what has been a series of small corner shops to a genuinely connected system with us as patients at the heart.
Achieving a digital NHS is a major ambition. A new Federation for Informatics Professionals, known as FedIP, has been set up to ensure that clinicians make the best use of digital technology to help patients and to safeguard that data.
With electronic and digital systems, you can lock that down. So as a receptionist, I'd only be able to see the demographic side of the data, just the name, address, those type of things that I need to do my job. Whereas at the moment, if I walked into a medical records library and picked up a case note, I've got access to everything. So I think with digitalisation, you will have much more control, much more security.
And now you can have a go. Excellent, good speed.
At King's College Hospital in London, they offer an app with a series of simple tests and medical reminders for patients like Brian Corbin with Parkinson's disease.
For those of us that work or are busy, then sort of general reminders about medication and things like that are just very useful indeed. And then the ability to sort of self-assure, self-test and track how your Parkinson's is going.
They can actually tell us what a good day is, what a bad day is, learn about their symptoms, understand their condition.
Many great innovations for healthcare often can't get the funding to become a reality. Equally, there are challenges for healthcare professionals that could really benefit from the expertise and innovation offered by entrepreneurs. This app was developed with the support of the NHS England-backed organisation Small Business Research Initiative for Healthcare.
We work with those frontline staff to understand what problems they're experiencing, and then once we've determined those problems, we then invite innovators and entrepreneurs to give us their great solutions and their great ideas, and we're able to fund the development of those ideas from concept through to a product that exactly matches the NHS specifications.
A world away from technology is the simple issue of communication, and yet this is one of the biggest sources of complaints by patients about the NHS. Poor communication between the myriad medical departments and different care providers is not only frustrating, it wastes resources. University Hospital Coventry is one of 280 hospitals across the UK using software that enables experts such as endoscopists to allow GPs to see endoscopy results at speed.
The actual report can be made available on our unique computer system, which most GPs in Coventry and Warwickshire have access to. There's no concern with losing a report or another clinician saying we don't know actually what that finding was.
Now they punch it into the computer and the report's immediately available on the GP's desk before even the patient has left the hospital.
The huge benefit of systems are its speed, and then the papers are not lost in the post, and the confidentiality.
Communication between wards, departments and between hospitals within a trust is another area where a paradigm shift is desperately needed to make better use of precious resources. This dashboard, powered by software, enables these doctors, nurses and managers at the Clinical Decision Unit in William Harvey Hospital in Ashford, Kent, to understand business intelligence in real time across 4 hospitals in the trust.
In A&E and CDU, we will look at it to monitor how busy we are,
compared to how we've done recently. We'll look at it to track the flow of patients through the day. So when do we expect those sort of peaks and troughs of patient activity? And we'll be doing modelling to predict when we think it's going to get busy, and we'll use that data in ClickView to help us sort out the rotas of when we need more people in and less people in. And the aim being that we can predict when something's going to get very difficult before it happens.
Doing the job I'm doing now without ClickView, to get the information that I can get off ClickView, would only have been made by making phone calls to each site to find out how busy they are. And I think anybody that currently works to that system will appreciate that sometimes that is very person specific. So you get one story of one person, one story of another person. So it was always very difficult to actually get your information.
It's all about understanding the bigger picture, which also means predicting and preventing some of the growing and most dangerous conditions affecting our ageing population, conditions such as cardiovascular disease and diabetes. The number of people diagnosed with diabetes in the UK has increased to more than 3.2 million. 8% of UK adults are registered as diabetic. Another 850,000 are estimated to have diabetes without knowing it. The statistics are largely fueled by type 2 diabetes linked to lifestyle and obesity. 10% of the NHS budget is spent on diabetes and its consequences. With the government looking at a shortfall in funding, preventative measures are desperately needed. In Salford, 1 in 10 men over 60 has diabetes. They're implementing a new care pathway, identifying through early diagnosis with a preventative approach.
Diabetes, very expensive from a patient point of view and health service point of view. If we can prevent it, we save lots of ill health from the patient's perspective, we save lots of cost from the health service perspective. We think we can do that. We've been working on that for a few years now. We can do it remotely using a contact centre based approach over the telephone. People like that, but it could be more efficient, it could be more effective.
GP surgeries are often the first port of call. Keen indicators are measured, and depending on outcomes, people are referred to a specialist diabetes team in the city.
I think it's extremely important to diagnose diabetes early, and also to pick up people who are at high risk of developing diabetes later on. So if you can pick them up early and hopefully prevent them actually getting diabetes, that's a really important thing for everyone.
How's stuff with your diabetes at home? How are you managing?
At Musgrove Park Hospital in Somerset, Julia Hicks works with diabetes patients to better manage and monitor their condition using innovative technology. Before a pancreatic transplant, she herself used to have type 1 diabetes, so she provides a unique insight.
There's no holidays from diabetes. It's literally on your mind 24/7 really, and as much as you try to put it to the back of your mind and try to get diabetes to come and live with you, it does take over.
Which is why she believes it's vital to raise awareness of all the new technologies and devices available to help diabetic patients manage their condition.
Diabetes is very expensive for the health service. So it consumes currently about 10% of the health service budget, and that's projected to go up fairly easily to 20% of the health service budget.
West Berkshire now implements a multidisciplinary network approach, with 50% of diabetes patients there using the same testing strips from one company.
They're one of the most cost effective for us. There's many meters on the market, and it's just making sure that we get a meter which is cost effective but also meets our needs. But more important, obviously meets the patient's needs as well.
Across the UK, health providers are working hard to engage patients in the management of their own health, like this cardiovascular rehabilitation programme in Wickham Hospital.
In the past, about 50% of people would be looking for cardiac rehabilitation, and the other 50% weren't really that bothered. I think it's partly because we didn't have a bespoke area in the hospital where we could offer it, where comfortable surroundings with good educational material.
All of the patients that we see, we will offer them a cardiac assessment, and that will be with a nurse professional and a clinical exercise professional. When they come, they will have a functional capacity test, and we will give them a personalised programme for them.
But an even greater challenge comes from engaging with people who are harder to reach, narrowing the gap in health outcomes for some of the most vulnerable groups in Britain.
Why should being poor make you ill? It seems very unfair, and
I've proved that not to be the case. I've proved with different ways of thinking and working that we can impact on population health within our disadvantaged communities on a huge scale.
The Trident Reach trial in Birmingham is working with GPs to reduce the readmission cycle for patients who are homeless. Crucial to this was understanding the link between poor health and poor housing.
A lot of our customers had been in and out of hospital on a number of occasions. We would often get people from hospital, but we would get them at the point that they've been discharged. So unfortunately, the options for that person were few and far between. What we can do now is identify them at the point of admission and work with the clinicians on the ward to ensure that both their broad medical needs are addressed whilst they're in hospital, and any welfare and housing issues that they need addressing are done so before they're discharged.
The role of the pharmacy in primary care is rapidly growing. Not only are patients able to seek advice in their local pharmacy, some GP surgeries are welcoming pharmacists into the GP setting.
Hospitals have their specialist pharmacists that they can get advice from, and I think we're quite isolated in general practice. So that was kind of a big additional incentive and attraction for me to be thinking there'd be someone there we could get help from readily.
My patients speak for themselves. A lot of them actually just want to see me, and they'll wait weeks to see me. So it's about the confidence that you give back to them about their medicines, listening to them, understanding what they have to say, and actually relating it to how they live, making it personal.
Hello, Sylvia. Hello. Lovely to see you again.
And that personal care, reaching out into the community, is changing the traditional way that GPs deliver primary care. This nursing home partners with a local GP so that it offers regular consultations by a GP on site and can be far more proactive in the care offered to residents.
The benefits of the GP coming to the home are that he develops a great rapport with the people who live here. He sees them in a natural environment. They consequently open up to him. He sees them in a well state as well as an unwell state, and therefore they get the best treatment in the right place at the right time, every time.
Communities are rising to this challenge, showing imagination and ambition. Crawley in West Sussex is a place where everyone from the transport providers, the banks and of course healthcare providers are working to make Crawley a dementia-friendly town.
I think the main significant influencer on this has been the involvement of people with lived experience, those living with dementia, their carers, their family, in informing us and guiding us as to what that really should look like. And I think that's why we're seeing so many changes.
It's about challenging traditional ways of providing care, building stronger relationships between primary care providers and the people they care for, empowering and supporting everyone in society to be able to live full lives, and harnessing technology to enable all patients to have much more say over the way they live and how they're cared for.
Too many people are doing heroic 14-hour days and doing what they can to keep the current system going. Actually, if they let some of those other partners in the system take some of the strain, it would probably work better for all of us.
Charlotte Hume reporting there. Well, thank you for watching NHS Alliance TV. You can see more in-depth reports on the screens around the conference centre, and go to nhsalliance.org to share the videos on social media and with your peers and communities. From me and the rest of the team here, goodbye.